So, imagine going into a clinic to, enhance your most intimate experiences.
Right, something a lot of people do.
Yeah, exactly. But you walk out, and instead of this great result, you end up with, like, an asymmetric, hardened lump.
Oh, yeah, that's not what anyone wants.
No, definitely not. And we're talking about a lump that causes um, constant unwanted arousal just from sitting at your desk.
Wow, just sitting there.
Literally just sitting there, or, sharp misaligned friction during intercourse,
Right.
because you went in wanting enhanced sensitivity, and instead you got basically a mechanical failure in a very, very sensitive area.
Yeah, that's a serious complication.
It really is. So welcome to today's deep dive, everyone. Today we're looking at the realities of intimate aesthetic medicine, specifically G-spot amplification, which is often called the G-shot.
The G-shot, yeah.
Right. But we aren't just looking at when it goes right. We're diving into what happens when things don't go according to plan.
Which happens, unfortunately.
It does. And more importantly, we're going to look at the hardcore, like, biochemical protocol that doctors use to reverse it.
The undo button, basically.
Exactly, the molecular undo button. We are tracking the clinical steps to resolve an asymmetric G-spot filler projection.
And the margin for error in this specific area of the body it's incredibly unforgiving.
I can imagine.
Yeah, I mean, when you're dealing with functional anatomy, especially anatomy that's explicitly designed for complex movement, tactile feedback, pleasure,
Right.
literally a millimeter of misplaced volume can completely distort the biomechanics of the whole pelvic region.
A single millimeter.
Just a millimeter. It's that precise.
Wow. Okay, well, before we get into, how to dismantle a botched procedure, we probably need to establish what's actually being put into the tissue in the first place.
Good idea.
So the standard protocol for a G-shot involves targeting the anterior vaginal wall. And the clinical sources we're looking at, they are super specific about the coordinates here.
Oh, they have to be.
Yeah, they say the practitioner is aiming for the submucosal layer, which is roughly 2.5 centimeters posterior and 2 centimeters lateral to the mid-urethra.
Yeah, and that precision is absolutely paramount because of all the surrounding structures.
Right, you don't want to hit the wrong thing.
Exactly. And the material they're depositing into that submucosal layer, it's almost universally a biocompatible, cross-linked hyaluronic acid filler.
Okay, hyaluronic acid, or HA. We see HA everywhere now, right?
Oh, yeah, everywhere.
Like, it's the cornerstone of facial aesthetics, lip fillers, hydrating serums.
Skincare, yeah.
Right. And biochemically, it's a glycosaminoglycan, right? Which is basically just a massive sugar molecule that already naturally occurs in our bodies.
That's exactly it. And its main native function is binding water to maintain tissue hydration. It basically acts as this incredible biological sponge.
Oh, yeah, a sponge.
Right, but native, like endogenous hyaluronic acid, it has a very rapid turnover rate in the body.
Meaning the body just gets rid of it quickly.
Yeah, exactly. Your body naturally produces enzymes that are constantly breaking it down and recycling it. So if a clinician were to just inject pure, unadulterated hyaluronic acid into the vaginal wall,
It wouldn't last.
it wouldn't last at all. The body's natural metabolic processes would just clear it out within, like, a few days.
Oh, wow. Just a few days.
Yeah. And obviously that doesn't serve the purpose if you're looking for a long-term cosmetic or functional enhancement.
Right. You don't want to go back every week for a top-up.
Exactly. So to get around that rapid breakdown, pharmaceutical companies use chemical cross-linking.
Okay, and what does that actually mean?
Well, they take those individual chains of hyaluronic acid and they bind them together, frequently using something called BDDE technology.
BDDE. Wait, that stands for, let me check, 1-FU-4-butanediol dilucidal ether.
You got it. Yeah, it's a mouthful. But that chemical process transforms the HA from, like, a liquid solution into this highly durable, three-dimensional gel network.
Okay, so it makes it tough.
Super tough.
Yeah.
That 3D architecture is the entire key to the filler's longevity.
Because it protects it.
Exactly. The cross-linking physically shields the HA chains from the body's naturally occurring enzymes. It prevents that immediate degradation.
Got it.
But, in the context of the anterior vaginal wall, this gel network has to do way more than just survive enzymes.
I mean, yeah, it's a very active area.
Right. It has to withstand immense, repeated physical forces. It must endure the heavy mechanical shear stress of pelvic floor contractions and, of course, the intense physical pressure of coital friction.
Right, without squishing or moving.
Exactly. Without migrating or just flattening out completely.
Okay, so thinking about it mechanically, it's kind of like putting a customized high-density gel insert into a running shoe.
Oh, I like that analogy.
Right, like you intentionally alter the fit and change the friction points. And you absolutely need that gel insert to be resilient enough to handle the constant impact of running without just, instantly losing its shape.
That's a perfect way to look at it.
But okay, here's my question. If the filler is chemically engineered to be that robust and that resistant to friction, what actually goes wrong? Like, how does it end up forming this uncomfortable asymmetric projection in the first place?
Well, the complications stem from a few intersecting variables. It's not just one thing.
Okay.
Often, it begins with the initial delivery of the filler. If the practitioner's injection technique is even just slightly off, or they fail to distribute the gel evenly across the tissue plane,
It bunches up.
yeah, the material can pull. And then you also have the reality of the tissue dynamics in the anterior vaginal wall itself. It's an intensely vascular and highly mobile area.
Right. So even if the injection is absolutely perfect, the material could theoretically shift post-procedure, like before it has time to settle and integrate.
It can definitely migrate, yeah.
Yeah.
And beyond just mechanical shifting, you have to account for the patient's individual immune response.
Oh, right. The body fighting back.
Exactly. The body occasionally recognizes this dense, cross-linked gel as a foreign body.
Because of the cross-linking chemicals.
Yeah, and just the sheer density of it. So in response, the immune system attempts to wall off this perceived threat by generating a localized fibrous capsule around the filler.
So it basically builds a wall around the gel.
It encapsulates the gel entirely, which creates this hardened, isolated nodule that completely distorts the surrounding tissue.
Okay, so that biological encapsulation process, that explains the shift in texture that the sources mentioned, because the clinical presentation of this failure isn't just like a slight unevenness.
Oh, no, not at all.
Patients present with what they call severe tissue induration, which basically means the area feels abnormally rigid and hard.
It turns into a rock, basically.
Right. And given the anatomical neighborhood, a misplaced or hardened lump of filler has some pretty crazy cascading effects.
Very serious effects.
Because it's so close to the urethra, that asymmetric nodule can physically press against the urinary tract, right? Creating a mechanical obstruction that leads to urinary retention.
Yeah, and physical obstruction of the urethra is a significant medical concern that requires immediate intervention.
Absolutely. And then on the sensory side, the G-spot region is, intimately connected to the broader clitoral network.
Highly innervated, yes.
Right. So when an asymmetric hardened nodule exerts constant localized physical pressure against those nerve bundles, it can trigger like continuous unwanted wetness or just a persistent state of physical arousal.
And that occurs entirely passively.
Passively, like without any mental...
Right. Regardless of the patient's actual psychological state, it can happen simply from walking, sitting down, or just wearing fitted clothing.
Wow. That sounds miserable, actually. And obviously, during intercourse, the intended enhancement is completely lost.
Exactly.
Because instead of a broad, compliant area of sensitivity, this rigid lump creates painful, misaligned friction vectors. The entire biomechanical purpose of the anatomy is just compromised.
It's working against you at that point.
Right. But wait, couldn't this also just be a classic case of patients asking for too much? Like more is better gone wrong. We see patients requesting massive volumes of filler in facial aesthetics all the time.
We do, yeah. Pillow face, they call it.
Exactly. So if someone demands, 3 or 4 milliliters in an area that can really only accommodate 1, the tissue just can't handle it, right? Is volume a factor here?
Oh, absolutely. The clinical data heavily supports volume as a primary risk factor.
Oh, okay.
Injecting anything over 3 milliliters into this specific anatomical space significantly elevates the risk of asymmetry and nodule formation.
3 milliliters is the limit, basically.
Pretty much.
Yeah.
The tissue simply cannot accommodate the displacement beyond that, but depth is actually just as critical as volume.
Depth of the injection.
Right. The intended target plane for the G-shot is Halban's fascia, which is a deeper connective tissue layer.
Okay, so what happens if they miss that layer? If the needle doesn't reach Halban's fascia and the clinician deposits that thick gel, too superficially, like right into the mucosal epithelium,
Then it has nowhere to integrate.
it's just stuck there.
Yeah, it's just sitting right under the surface of the skin, and it is guaranteed to cause an uneven projection.
Got it. And because this is a gel that's integrated into the mucosal tissue, a surgeon can't just go in with forceps and pluck it out, right? Like they would with a solid silicone implant.
No, they can't. It's completely enmeshed in the tissue. It requires a biochemical intervention.
So they have to melt it.
Precisely. The clinician has to dismantle the filler at the molecular level, using a specific reversal agent. Which brings us to the protocol for hyaluronidase.
Okay, yes, the hero of the story, often branded in clinics as Hylenex, right?
That's the one.
This is the chemical undo button. It's a purified preparation of recombinant human hyaluronidase, which is synthesized as this complex enzyme containing 447 amino acids.
And its sole biological function, the only thing it does is catalyze the hydrolysis of hyaluronic acid.
Hydrolysis.
Right.
Okay, since this relies on hydrolysis, we are basically using water to shatter the chemical architecture of the filler.
Right, breaking it apart with water.
The enzyme zeroes in on the Betwite-1,4 glycosidic bonds.
Good pronunciation,
Yeah, thanks. Those are the specific chemical linkages holding together the alternating units of N-acetyl D-glucosamine and glucuronic acid that form the long HA polymer chains.
Exactly. So the enzyme depolymerizes that massive cross-link structure. It aggressively cleaves those specific glycosidic bonds, which breaks the long, resilient chains into tiny little oligosaccharide fragments.
Okay, let's unpack this with a visual. Because if we think of the highly cross-linked HA filler as like a tightly woven, heavy-duty fishing net that's tangled up in the tissue,
Right.
hyaluronidase doesn't just act like a bomb destroying the whole area. It acts more like millions of microscopic chemical scissors that only cut the specific knots holding the net together.
That's a great way to visualize it.
And once those specific knots are severed, the entire structural integrity of the net just collapses, right?
Exactly. The gel state completely deteriorates. Because the HA have been cleaved into microscopic fragments, it totally loses its macromolecular ability to bind water.
So it stops being a sponge.
Right. It immediately transitions from a resilient, space-occupying gel into just a thin fluid.
Oh, wow. And from there, the local tissue macrophages and the body's lymphatic drainage system naturally collect those tiny fragments and just clear them from the area.
Yep, the excessive volume is metabolized and it simply vanishes.
Just washes away. Okay, so understanding that biochemistry is super cool, but deploying it in a clinical setting to resolve an asymmetric friction lump in such a sensitive area that requires a highly meticulous sequence of events.
Highly meticulous. The clinician is navigating distorted, highly sensitive anatomy. It's not easy.
So the first phase of this resolution is the physical assessment and preparation. The clinician has to physically palpate the anterior vaginal wall to map out the exact dimensions, borders, and critically, the depth of the asymmetric nodule.
Yes, depth is everything here.
And because they are operating inside the vaginal canal, strict aseptic technique isn't just like a precaution, it's the absolute foundation of the procedure.
It has to be. The vaginal canal harbors a very complex microbiome. If a practitioner fails to thoroughly sterilize the mucosal surface before introducing a needle,
They'd push bacteria in.
exactly, they risk dragging native vaginal flora deep into the sterile submucosal space or into the fascia.
And that would cause an infection.
A severe deep tissue infection, yeah, which would just horribly compound the patient's existing complications.
Wow. Okay. So once the mucosal surface is sterilized and the nodule is perfectly mapped out, the targeted injection phase begins, which sounds incredibly difficult, honestly, because the injection depth of the hyaluronidase has to perfectly mirror the location of the errant filler.
Right. They have to match it exactly.
Right. Like if the filler pooled superficially in the mucosa, the enzyme needs to be delivered superficially. But if it's buried deep in Halpin's fascia, the needle has to reach that exact same depth.
And the physical reality of this step can be quite brutal, honestly, both for the clinician to execute and for the patient to endure.
Brutal how?
Well, as we discussed earlier, these nodules often feature a hardened, fibrous capsule generated by the body's immune response.
The wall the body built.
Right. So the clinician must forcefully, yet precisely, drive the needle through that tough, gristle-like capsule to ensure the enzyme is deposited directly into the core of the cross-linked gel matrix.
Because if the enzyme is just deposited into the healthy tissue next to the encapsulated lump, the chemical scissors will never actually reach the tangled net.
Exactly.
Yep.
The capsule acts as a biological shield. The enzyme absolutely must be delivered intralesionally.
Into the lesion itself.
Yes. But simply getting the liquid into the center of the nodule isn't the end of the intervention.
Right, this next part is wild. The sources talk about the next phase being a vigorous, immediate post-injection massage of the treated area.
Yes, vigorous massage is required.
That sounds wildly uncomfortable. Forcefully massaging a hardened, sensitive nodule inside the anterior vaginal wall immediately after multiple needle punctures.
It's not pleasant, no.
But biochemically, the mechanical dispersion is mandatory, right? Because the filler is a dense, stubborn, three-dimensional gel engineered specifically to resist breakdown. And the enzyme, on the other hand, is just a highly fluid liquid.
Exactly.
Hmm.
If the clinician just injects the liquid enzyme and stops, it will likely just pool in whatever small cavity the needle created.
It'll just sit there.
Right. It won't permeate the broader matrix.
Okay, so if you don't do the vigorous mechanical massage, it's like um, pouring liquid stain remover onto a really thick, high-pile carpet and then just staring at it.
Yeah, that's exactly it.
Right, the liquid will just sit on the surface, or it'll just pool at the base of one single tuft of carpet.
Hmm.
You have to actively scrub the liquid into the fibers so it actually comes into contact with the entire stain.
That's a great analogy.
Hmm.
Here, the doctor is physically crushing the tissue to force the enzyme throughout the entire 3D gel matrix.
To maximize the surface area.
Right, so the chemical scissors can actually access all of those glycosidic bonds. The mechanical pressure actively drives the chemical reaction. And without that aggressive dispersion, the dissolution will be patchy. It'll leave behind fragments of the nodule and ultimately fail to resolve the asymmetric friction.
Okay, so after the brutal massage, it basically becomes a waiting game. The enzyme begins depolymerizing the gel immediately, and the tissue starts to deflate as the fragments lose their water-binding capacity.
Works fast, yeah.
Right. The clinical sources indicate that the enzyme typically reaches its peak effectiveness within just 24 to 48 hours.
And patients generally experience rapid relief from the constant pressure and those misaligned friction vectors during that window. The volume reduction is usually profound.
That must be such a relief.
It is. However, clinicians rarely achieve 100% dissolution in a single session, especially if the original filler was heavily cross-linked or if a really large volume was used initially.
But the protocol strictly prohibits going back in the very next day to hit it with more enzyme, right? The standard of care requires waiting a minimum of 2 weeks before evaluating for a follow-up treatment.
Yes, the 2-week delay is absolutely critical for tissue recovery. You have to think about what the tissue just went through.
Right.
You have the combination of the original hardened nodule, the needle trauma, the aggressive massage we just talked about, and the local enzymatic activity.
Mhm.
It all causes significant secondary tissue swelling.
So if a doctor evaluates the area at, say, day 4, they are likely looking at inflammatory edema, not leftover filler.
Exactly. And if they inject more enzyme based on that temporary swelling, they're setting the stage for massive overtreatment.
Which is bad.
Very bad. Overtreating with hyaluronidase introduces a very serious set of collateral risks because this enzyme is entirely non-selective.
Okay, wait. Let's dig into that. When you say non-selective, the recombinant hyaluronidase is programmed to cleave hyaluronic acid,
Right.
but it doesn't possess any mechanism to differentiate between the synthetic, cross-linked HA in the cosmetic filler and the endogenous natural hyaluronic acid that forms the structural extracellular matrix of the patient's own native vaginal tissue.
No, it doesn't know the difference at all. It just sees HA and cuts it.
Oh, wow. So it's essentially a chemical scorched earth policy.
That is exactly what it is. If the dosing is too aggressive or the placement is too diffuse, the enzyme will aggressively degrade the patient's natural tissue hydration and structural integrity.
And what happens to the patient then?
Well, the immediate consequence of degrading the native HA is a sudden loss of tissue turgor. The anterior vaginal wall can become temporarily lax, thin, and highly fragile.
That sounds terrifying.
The body will naturally regenerate its own hyaluronic acid over the following weeks to rebuild that extracellular matrix, so it's not permanent.
Okay, phew.
But in the interim, the patient may experience significant discomfort and tissue vulnerability.
Right, which totally highlights why conservative dosing, like undertreating and waiting 2 weeks, is vastly superior to attempting to just obliterate the nodule in one massive dose.
Absolutely.
And beyond the collateral damage to native tissue, there is also the overarching risk of severe allergic reactions, right?
Yes, that's another major factor.
Because despite being a recombinant human enzyme, hypersensitivity to hyaluronidase is a well-documented clinical phenomenon. Patients can mount an immediate localized immune response to it.
They can. And an immediate hypersensitivity reaction in the mucosal tissue of the vaginal wall. I mean, that means sudden, severe swelling, intense erythema, and profound itching.
A localized allergic crisis.
Basically, yes. And this is why the clinical guidelines strongly advocate for performing an intradermal skin test on the patient's forearm before introducing the enzyme into the pelvic anatomy.
Oh, smart. So they check the arm first.
Yeah. Because discovering a severe allergy while injecting a highly vascular mucosal surface is a scenario every practitioner wants to avoid.
Obviously.
The forearm skin test provides a controlled environment to monitor for wheal and flare reactions, though practitioners must also warn patients that delayed hypersensitivity reactions can still occasionally manifest 24 hours post-injection.
So they might need like a protocol for antihistamines or corticosteroids just in case.
Exactly.
Man, when we pull back and look at the entire landscape of this deep dive, it completely reframes the concept of aesthetic medicine for me.
Doesn't it?
Yeah, because a procedure like the G-shot, it's marketed as this straightforward augmentation to enhance intimacy. But when the mechanics fail, whether it's poor technique, filler migration, or biological encapsulation, the result is this asymmetric projection that actively antagonizes the patient's daily life.
With painful friction, urinary retention.
Or unwanted arousal. And resolving that failure isn't just about removing volume, it demands an incredibly sophisticated understanding of biomechanics and pharmacology.
It really does. The clinician has to navigate a sterile field in a complex mucosal environment, penetrate an encapsulated nodule, deliver an exact volume of an enzyme that targets precise glycosidic bonds.
And physically force that enzyme through a resilient gel matrix.
Oh, yes.
It requires knowing exactly how to weaponize biochemistry to reverse engineer a procedure when the body's anatomy rejects the intended design. You have to know exactly how to cut the net without destroying the surrounding ecosystem.
It is the ultimate exercise in controlled tissue modulation.
Absolutely. Which actually brings us to a final, slightly unsettling thought that I found in the clinical literature for today's deep dive.
Oh, what's that?
Well, we spent this time analyzing how clinicians deploy synthetic hyaluronidase to dismantle these cosmetic enhancements. But as we noted earlier, the human body constantly produces its own native hyaluronidase enzymes, right, to maintain and remodel our tissues.
Right, endogenous production. And that's heavily regulated by the immune system and cellular signaling.
Right. So the literature poses this fascinating physiological question. Can localized endogenous hyaluronidase activity spike during periods of systemic inflammation?
Oh, wow. That is interesting.
Think about the implications of that mechanism. If a patient experiences a massive immune response, perhaps a severe case of the flu, a significant systemic infection, or a profound autoimmune flare-up.
Their macrophages and immune cells are flooding the body with inflammatory cytokines.
Yes, and those cytokines can upregulate the production and release of native hyaluronidase across various tissue beds as the body attempts to manage the inflammatory crisis.
So their body produces way more of the enzyme naturally.
Meaning, it is theoretically possible that simply getting violently sick could inadvertently signal your own immune system to flood your tissues with hyaluronidase. Your body's own defense mechanism could accidentally become the chemical scissors, accelerating the breakdown and dissolution of your expensive, cross-linked cosmetic enhancements from the inside out.
That is, wow, the very immune system designed to protect you might just hydrolyze your aesthetic procedures while fighting off a fever.
Exactly. Something for all of you out there to think about the next time you feel a severe flu coming on. Thanks for joining us on this deep dive, and we'll catch you next time.